Today, we're going to talk about some musculoskeletal injuries. We're going to cover things like fractures, sprains versus strains, dislocations versus subluxations, a little bit of nerve damage, and then I have some special conditions that we're going to take a look at as well that deal with the musculoskeletal system. The body is absolutely amazing at what it can accomplish, the different positions that it can go in, how it can make us move, and the ways that it adapts. And we tend to push it to its limits, sometimes either on purpose, like our wonderful picture here, or sometimes on accident when we start to have injuries. So, there are millions of Americans who experience musculoskeletal injuries. Um, it can be from many different mechanisms of injuries, right? You can have falls, crashes, personal violence, and then also just things like multi systems trauma. So, as far as when we're taking a look at the anatomy and physiology of the musculoskeletal system, we are look like the purpose on why we have it, why we have bones specifically, is to protect things like some of our organs. Think about things that are highly covered in bone, like the brain, right? The skull is covering the brain completely, and that is probably one of our more important organs. I think we could rationalize that. We also have a lot of coverage over the heart and the lungs. Small intestines, not so much. They're not quite as important when it comes to, um, surviving, living, or dying. And so we don't have as many organs in that region. But now go back into our reproductive system, in which we're looking at survival of our species. And in the pelvic region, we've got a lot of bone there as well. Bones also allow for movement. So it is a way that we can actually move our body around by way two bones come together and make that joint. It allows for that movement. Our muscles also help us to actually produce those movements. Bones also store salts, other materials that are needed for metabolism, and this is actually where we produce our red blood cells as well as our white blood cells in the bone marrow. So these are kind of like all important reasons on why we have the skeletal system. So when we look a little bit deeper into the bones itself, what you can see here on the screen is, well, this is a long bone, an example of a long bone. There's several different types of bones that we have within our body. We're going to focus on long bones for just right now. It has a protective outer covering that just kind of gives us this smooth surface, and it helps to hold everything else in. Across on the top of it, you'll actually see the periosteum. The periosteum is just this outer covering of the bone, and this actually shown peeled back in this particular picture. But the periosteum on this outside of the bone is actually where a lot of the free nerve endings travel, as well as blood vessels are innervated here. So we can actually have and pass blood in between the bone itself on the inside and the outside world, and vice versa. So, and also has a lot of lymphatics in it as well. But imagine that if it has all these free nerve endings that we have here that are kind of shown in this yellow right here, whenever this r- um, peeling or this periosteum is damaged, it causes a lot of pain. So that's one of the reasons that we actually will know that a bone is broken, is because of the pain that's associated with there coming from the periosteum. The bone is also split into two different compartments that we can see here. We have the cavity right here, in which we actually contain all of the necessary structures to be able to create our red blood cells and our white blood cells. Then it has the blood flow that's in there. And then we also have on the ends of our bones our more spongy bone. On the very ends of all of our long bones, we actually have a little layering of cartilage, which helps to block any and absorb shock, and create a smooth surface as it's going around to the other joints. So when it's coming in contact with another bone. So as I was talking about, the vessels enter through the periosteum, And this has a lot of sensory nerves in that area, so it feels quite painful when it is disrupted or torn. And really, it's kind of our lifeblood. It's what keeps our bones alive. Without it, the bones would end up dying. When there's disruption to it, we need to make sure that it is in a place that it can heal properly. Otherwise, the bone will end up dying. Beyond bones, we also have skeletal muscle as well. This is basically the form of all of our movement, right? Being able to pull two bones closer together in angle will create these movements for us. In this class, we don't necessarily have to know what all the different muscles are that exist, except I would like you to know the three different categories. So, three different categories of muscles that we have are skeletal muscle, which in these two pictures is everything that we see here. So those are all of our skeletal muscles. Then we also have specific muscle for the heart, cardiac muscle. And then lining our digestive system and all of our blood vessels is our smooth muscle. The great thing about cardiac muscle and smooth muscle is that it can actually operate on its own, versus skeletal muscle is both voluntary and involuntary. So it depends. We can produce movement when we want to, but also we have reflexes that will cause movement as well. So whenever we have a bone and a bone come together, this is considered a joint. What we're looking at here is a type of a synovial joint, which are the ones that actually produce movement. We have other joints within our body that have bone against bone, but they don't actually produce a lot of movement. So here's some examples of what we have. We've got the ball and socket joint. You'll find that in your shoulder. Or in your hips. We have condyloid joints, which you can see, these are actually fingers, that they could be toes too, but they're fingers that are coming together. And so it's just the different knuckles that we have. We have gliding joints, like between our clavicle right here, our collarbone, as well as our scapula. So in this joint, it's a gliding joint. We have hinge joints that do a lot more movement, but it's only in one direction. So think of things like your elbow would be a good hinge joint there. A pivot joint is anything that's going to rotate around an axis. So here's a picture of our cervical spine, so up in our neck, to be able to allow us to shake our head no. That's caused by a pivot joint. And then we also have saddle joints, and it's looking at the shape of it and that it's actually like creating a saddle that's sitting in there. All of these different types of joints have this wonderful synovial membrane that's surrounding the bone on each side and creating this capsule. So there's a lot of fluid that you'll actually find within here to be able to act as a shock absorber and can help deal with inflammation. It's also how we actually get nutrients to the end of our bones in these types of areas. So you can see we've got a bone up above, a bone down below. We've got this cavity that's right here full of synovial fluid in between. So now when we talk about breaking bones, another word for that is a fracture. Here's just a couple of hand drawings that what you can see of different types. So you've got the comminuted, which is when it's broken in many different places. Impacted is when it's come closer together, to the two ends have come closer together and has compounded or impacted in that area. Green stick, you can see here, is just when it's a portion of the bone that's broken and it's off into splinters. Often if you were to take a green branch, like a branch that was still somewhat healthy and alive, and you try to bend it, there's a point in which like the splinters start to, break off from each other, but yet it's still connected on the other side of the stick. That's what this fracture is as well. Oblique is when it's done at an oblique angle or a diagonal angle. A spiral is a twisting motion. And then the transverse is when it's straight across. So those are different ones. When we're looking at things like the oblique and the transverse that are just in one spot right there, we call those simple fractures versus the comminuted, which is the multiple breaks. So I'm going to show you also a couple pictures that we have of actual x-rays to kind of see what it looks like in the real bone as much as possible. So here's a comminuted break that we have right here, and this is on our humerus. So you can see there's multiple breaks that are along the side of the bone, and it can't be fixed with just a simple cast. This is when they actually have to go in and do surgery to be able to piece everything back together again. So that's one example of our breaks. Here's what you can see is a green stick fracture. Here we've got a tibia on this side and a fibula on this side. So these are our bones of our shank or of our leg, the lower portion of it. And here you can see where the break is coming in on this side and also on the fibula on this side, but the bone is still intact here. This is usually indicative that it's probably a kid. I can't necessarily tell by the entirety of the size. I can actually look above and see that we don't have fully formed femur up on the top and the ends of the bones here. So I can actually see that it is a kid in that way. But when the bones are still really moldable, still really pliable, when we're in our younger, ages, and we all of a sudden have a bending to the bone, it can open up that bone on this one side, but still keep it connected on the other side. And that's our green stick. Here's an example or two examples of oblique fracture. So it's just a fracture that's a simple fracture that it's only on one area of the bone, but it's at an angle. So that's the oblique fracture. Transverse is when it goes straight across. So here you can see it's just kind of straight across. Sometimes these can be combined as well, where it's kind of like half in between a traverse and an oblique. So here's that example here. You have a transverse break with an oblique component to it, where it looks like it's straight across, but still there's some jaggedness that's there as well. Here's a transverse clavicle fracture, and this is a cool picture because you can see it here in the bone itself, just cut, broken right here across the straight of it, and you can actually see it with the skin on it. So what does that look like when it's underneath the skin? So, when we think about bone fractures, and many of you have probably had some type of a fracture at a time, let's take a look at what the typical symptoms are of a fractured bone. So, think back to your own experiences of maybe what you've experienced in your life, or if you've had a family member who's broken a bone. And I think that we could all agree that pain and nausea definitely come with it. Reason why we're getting this pain and the nausea, besides just tissue damage, is specifically because of that periosteum. So that periosteum is there and disrupted, and that's hitting all of those free nerve endings and making it so that it's causing us pain. That also starts to induce nausea, right? We are seeing some signs and symptoms of shock that are starting to set in. We're going to go ahead and upregulate our sympathetic nervous system because of a response to this fracture, which is going to take blood flow away from the stomach, which is going to make us nauseated. So when we look at it, it's the nerve endings of the periosteum. So now let's take a moment and look at sprains versus strains and what the difference is between these two types of injuries. So first we've got to take a look at what's the difference between a tendon and a ligament. Ligaments are what attach bone to bone. So ligaments are the structures around the joints that are attaching bone to bone, and it helps us to restrict movements so that the joint only goes in the direction that we want it to. Tendons are what attach muscle to bone. They're actually just connective tissue that's coming off from the outside of the muscle into basically a terminal point, and that is what is connecting the muscle to the bone itself. Now, when we talk about muscles, though, often in class, we'll talk about the musculotendinous unit, meaning the whole muscle leading into the tendon itself. So it includes both the muscle and the tendon. So here's just examples of what we have right here. Here we have the quadriceps, we have the rectus femoris that's coming in, and this juncture between the muscle itself and the patella, the bone right here, and this actually will continue down and attach onto the tibial tuberosity as well. But this is where it becomes a tendon here because it's attaching the muscle to the bone. Here's an example of a ligament, which we have the femur that's coming in contact with the tibia and the femur in contact with the fibula, and it's attaching bone to bone. So these are our ligaments. Think of it like ligaments. It's like taffy. It's not like a rubber band where if you pull and elongate it and it just bounces right back into shape, right? Instead, it's more like taffy. You stretch it and maybe it goes a little bit back into shape, but really there's some damage that's happening there. Tendons, first of all, have a lot of blood supply to them, and so they're able to heal quite nicely. Not as much as when it's in the muscle, of damage in the muscle itself, but there is blood supply to these areas as well. And there's more elastic properties within this. So it's just looking at the difference between tendons and ligaments. So here's an example of an ankle sprain. Sprain is what happens to our ligaments. So I like to think of it as like twisting your ankle, or chronic issues with your knee sometimes, those are often sprains of some sort. So you can see there's a lot of inflammation, a lot of swelling, a lot of redness. This is all just the inflammatory response that's trying to heal the area. But this is an example of a sprain. Strains are what happen to muscles when there's damage to the muscle itself or to the tendon. So we strain a tendon. And I like to remember that because a T is in tendon and a T is in strain. So if that helps you, you can use that. The next one we're going to take a look at is our dislocations and subluxations. Dislocations, I think a lot of us already know what that means. It's when the shoulder or when the joint comes just completely out of its joint capsule. So that's a dislocation. A subluxation is when there's like a partial dislocation. It partially comes out of the socket. When we look at dislocations coming out of joint, one that this is just an example of one that we can have right here. It's called nursemaid's elbow, in which it's a dislocation of the radius. And here's another picture of it right here, where the radius actually just comes out of that joint completely. This is why we're taking a look at the picture of it, is because it is common in children as far as when they're doing this swinging motion. So when we extend the arms right here, it creates this ability to pop this radius right out of the annular ligament right here, causing a dislocation, which can be quite painful for the child. One way to be able to prevent this, if you just want to know that as a side note, as a side comment, is that if they bend their elbows to a 90-degree angle, first of all, if I make the rule that they can only do that, I will only swing them as long as they can do that. But it also tightens the muscles up around it and makes it so that the dislocation is less likely to occur. And they can't hold that position for very long. Here's another dislocation, right? What we can see right here is actually the humerus has come out of the glenoid cavity, and it has produced a dislocation right here at the glenohumeral joint. So this is an example of what it might look like with the skin still on, instead of just looking at drawing pictures of bones. Here's another finger dislocation, and they can, become either in the front or in the back. The premise is what we're going to, not us, but what needs to happen is we need to be able to pull this bone in the line of traction, and then it will hopefully be able to go right back into place where it belongs. This is not something that we are going to do in the field, but it's what's going to happen within the hospital. So we want to make sure that we're stabilizing everything so that damage isn't happening when we have those bone ends not in the proper position. Now, we talked about that sometimes we, like especially with pitchers, we're putting our bodies in very complicated positions. So a thrower's shoulder, or like a pitcher, must be lax enough to allow for excessive external rotation, but stable enough to prevent symptomatic humeral head subluxation. So we're looking at rotating our shoulder backwards and keeping it so that we need it to be relaxed enough to be able to do that, but so that we don't get a partial coming out of the joint. So here's just a picture where you can see that the body is amazing at being able to adapt to these different circumstances. So here's our external rotation. And what ends up happening is sometimes we can even be starting with training and the laxity of our joint capsule right here in our labrum, that the bone can actually start to come out of the joint partially. So it's something that can happen on purpose as far as that we're training for it, and it can also happen as a result to an injury. But I liked this example of just showing you what you can see as it's starting to come out of that joint. So taking a look at nerves, nerves are what allow for transfer of information either from the body to the brain or from the brain to the body. So we're going to specifically take a look at our motor nerves. So how our motor nerves are related to our muscle is that a nerve impulse will start within our brain, travel down our motor nerves. These are our efferent nerves, the ones that are trying to do something in the rest of the body. And it will go and innervate our muscles in order to get them to contract and produce the movement. So that's what allows for our muscles to be able to contract. So if there's damage to some type of a motor nerve, what effect do you think it will have on the muscle that it serves? You're right in that the muscle's not going to be able to receive that signal because there's damage somewhere along the way, and the person's either not going to be able to contract, or the person is going to be weaker at being able to do those movements. So you're going to learn a little bit more about this in a moment when you do the online learning assessment, but let's take a look at what kind of information do clinicians need to make an injury assessment. So what kind of things are they looking for? Now, we know that we can ask our sample history, we can look for those signs and symptoms, we can look and ask them about all the symptoms they're experiencing on that OPQRSTI that we have there. But other ways that other fields also look at it and that we should take into consideration is using the HOPS system in order to evaluate an injury. HOPS stands for history, observation, palpation, and special tests. So when we look at HOPS, history is like what we're getting in our pertinent history, like how have you ever injured this part of your body before? Tell me about what's going on. Did it start, just trying to get that information of like what led up to this and has it ever happened before? Observation is when you're actually just looking and watching what they're doing. Often this refers to like, are they guarding it to make sure that it's not becoming injured anymore? Are they walking on it or not walking on it? How well is it moving? We're making those kinds of observations. So this is very objective data in knowing that we are seeing this with our eyes. Palpation is when it comes to touching. So we're going to actually, start to feel, where does it hurt? Does it hurt here? Does it hurt here? At what point does it start hurting when I'm on this part that doesn't, as I work up the leg, whatever the case might be. But this is when we're actually touching it and seeing if there's any type of a deformity that we can feel. Then what will happen with an evaluation to injury are special tests. Special tests are ways to do like active, resisted, motions or passive motions. And you guys have an online learning objective that actually is going to walk you through all of those types of specialized tests. So we're going to skip over that part for right now. But here's what I want you to do. I'm going to put up a little piece of information, and I want you to tell me whether that fits within the history, the observation, the palpation, or the specialized test. So a clinician seeing a patient walk with a limp. That would be our observation, right? A patient reports point tenderness over the fibular head during an examination. So at this point, we are palpating them in order to induce that point tenderness. Point tenderness is when you touch it in one particular area and it hurts, but it doesn't next to it. So this is our palpation. Then we have a patient, no pain is experienced during active range of motion testing. As it would imply, this is our specialized testing. Good. So the ones that you will be looking at in your online learning objective is the range of motion tests of an active range of motion, a passive range of motion, and a resisted range of motion. So I hope you guys enjoy that lesson. It was actually lent to us from the University of Oregon, and it is a great way to look at different range of motion testing. Now, it's not something necessarily that we are going to do with all of our patients. However, it gives us good knowledge when people start asking us questions that we can at least kind of get an idea. We're not going to diagnose anything in the field. We're not going to say, oh, that looks like it's a fracture. Oh, that looks like it's a sprain or a strain or whatever the case is, right? But it gives us good information to be able to deal with our patients and handle them better. So that's why we have you guys doing that online learning objective. So now we're going to take a look at some of our other conditions that we can have that deal with the musculoskeletal system. These are different inflammatory or degenerative conditions. So things like bursitis, tendinitis, arthritis, in which you can have 3 different kinds of arthritis: osteoarthritis, which is more of a degenerative disease; rheumatoid arthritis, which is more of a chronic disease and very progressive and very debilitating. And then gout is also another type of arthritis in which you actually have uric acid crystals that are building up. So let's go over these just briefly. So within our joints, we have what are called bursa. And bursa are just fluid-filled sacs that make it so that things can move more smoothly in that joint surface, right? So here's an example of the olecranon bursa, which is just at the tip of our elbow right here. So whenever we straighten or extend our elbow, this bursa is going to help protect it from a lot of rubbing that happens in this area. When it starts to become inflamed, it can actually grow in size. And so we have inflammation of this bursa, which is what the bursitis is. And here's actually the picture that you can see on a person, where you get the redness, the swelling, the deformity that's in this area with the bursitis. Tendinitis is when we have just small little micro tears or inflammation within the tendons. So this is just showing us a couple of different tendons that this tends to happen with. The elbow is another one that we can see it with. But we just have inflammation in this area, small little micro tears that aren't quite tearing all the way, that creates an inflammation response. And that is what we call our tendinitis. It's inflammation of the tendon. Then we have our arthritis diseases. The first one was osteoarthritis, which is just a degenerative disease. Overuse, rubbing on the joints over and over and over again, it can start to wear and tear on these different surfaces, and it starts to cause a lot of pain in these associated surfaces. The articular cartilages that are on the ends of these bones start to rub against each other and create this damage, and that's what osteoarthritis is. So it's just from overuse of it, which is different from rheumatoid arthritis. Rheumatoid arthritis causes a lot of deformities in the person because of what's happening within the joint linings. So this is actually an autoimmune disorder in which the immune system is starting to attack itself, and it's specifically targeting these areas between the joints and the linings of these joints, like that synovial membrane. And it actually starts to create structure differences and changes. So that's what creates these deformities within the hands. It can happen in any of the joints. Hands are one of the more popular ones just because we use our hands a lot, but you can have it in other areas of the body as well. Like such as the spine, or within the knees, or within the feet and ankles. And then our third version or type of arthritis that we have is gout. And gout is because of urate or uric acid crystals that start to form in the joint capsules. Uric acid, it is produced naturally within the body, but it also is when we are breaking down different purines. And we can find a lot of uric acid and purines in some of our meats, organ muscles that we consume for organ meats, as well as some seafood. So when we're consuming a really high diet of these types of foods, or it's actually found in alcohol as well. And beer is one of the leading causes of gout. So, consuming a lot of beer, it starts to increase our uric acid within our system. It starts to build up within these joints. Cavities, and it creates a lot of inflammation in that area with the uric acid crystals built up as well. One of the places we see it the most common is here in the center of the screen on the foot, right at the base of the big toe. That's probably one of the most common places that we will find gout. So we can look for that on our patients and help answer questions if they're not sure what's happening to them. And then you can find it in other places as well, though. So you can find it on your fingers, you can find it along in your spine, and along in your knees as well. Here's just kind of showing you this clouded on this x-ray. You can see the clouded buildup of all of that uric acid crystals that's forming there. And then you can see this picture down below of what it looks like. This is when gout has been left untreated for an extensive period of time. It can become extremely debilitating. And so you can imagine how that might panic somebody who isn't familiar with what's happening to it. This in the center, they could wake up with this the next morning or develop it within a couple of days. So it doesn't take very long for us to develop something like what we can see right there on the foot. But that is another type of our arthritis, is looking at gout. So that's what I have for you guys today as far as musculoskeletal. As far as treatment goes, we're going to be dealing with that in lab. You have already looked at splints, and whether it is a fracture or a sprain or a strain, we just need to be immobilizing the area, protecting it from damage, and making sure that we're not causing any additional damage to it.